Okay, so that's a bit about the cranial nerves. Let's talk about the spinal nerves. There are 31 pairs of spinal nerves. There's 8 cervical spinal nerves, 12 thoracic spinal nerves, 5 lumbar, 5 sacral, and 5 coccygeal 1 coccygeal spinal nerves. Now, how is it that there can be 8 cervical spinal nerves? Well, that has to do with the numbering system of spinal nerve roots. In the cervical spine, the spinal nerve roots are named for the vertebra below the nerve root. Let me say that again. In the cervical spine, spinal nerve roots are named for the vertebra below the nerve root. So, if we have a nerve root, we look to the vertebra below to name that nerve root. So, for example, the C1 nerve root is named for the vertebra below it, which is C1. So the C1 nerve root comes out above the C1 vertebra. The C2 nerve root comes out above the C2 vertebra. That pattern continues down throughout the cervical spine. And throughout the remainder of the spine, once we get below the level of T1, the remainder of the spinal nerve roots are named for the vertebra above the nerve root. So when we get to T1, the nerve root that comes out between T1 and T2 is named for the vertebra above the nerve root, which is T1. When we get to C7, the C7 nerve root is named, it comes out above the C7 vertebra, because in the cervical spine the nerve roots are named for the vertebra below the nerve root, and there's a transition at the cervical thoracic junction such that it's the C8 nerve root that comes out above the T1 vertebra. Okay? You got that? And then as we continue down the thoracic spine and into the lumbar spine and all the way down even into the sacral spine, the nerve roots are named for the vertebra above the nerve root. So when we get down to L5S1, it's the L5 nerve root that comes out below the L5 vertebra. Did you get that? Okay. There may be a quiz on that later, so make sure you have that concept. Okay, now the AMA guides on page 480, they talk about the spinal nerve roots. And they talk about 3 main groups of different types of fibers that travel in the spinal nerve roots. Now, so far, we've already discussed 4 different types of fibers, for example, traveling in the cranial nerves. We had special sensory motor fibers. We had special sensory afferent fibers. We had somatic motor fibers, and we had somatic sensory fibers. So let's read what the AMA guides say on page 480. This is a quote. It says that the spinal nerves, of which there's 31 pairs, they contain 3 main groups of fibers. The sensory afferent fibers carry to the central nervous system impulses arising from various receptors in the skin, muscles, tendons, ligaments, bones, and by bones we're talking about the periosteum, the mineralized bone, and the bone marrow, and also from joints. And those various receptors in joints are known as mechanoreceptors. So what is that talking about? That's talking about sensory afferent fibers coming from the dermatome, the myotome, and the sclerotome. And all of these fibers have their cell bodies located in the dorsal root ganglion. All of these cell bodies and all of these fibers are derived from the neural crest cells. These are known as GSA, general somatic afferent fibers. These spinal nerve roots also carry motor efferent fibers, known as general somatic efferent fibers. Now, these include the large alpha motor neurons, which conduct impulses from the spinal cord to skeletal muscle fibers, and also include smaller gamma motor neuron fibers, which carry impulses to muscle spindles, and muscle spindles we'll talk about more in a little bit. And these impulses and muscle spindles are responsible for feedback control as part of the proprioceptive system. In addition to those, spinal nerve roots also carry autonomic system fibers, which are efferent motor fibers, and are concerned with the control of smooth muscles and glands. Smooth muscles and glands. And when we talk about glands, what kind of glands can you think of? Well, with regards to the cranial nerves, we already talked about some of the different kinds of glands that we find in the head and neck. For example, we have the lacrimal glands of the eyes, we have the salivary glands, we have the parotid glands. Okay, those we talked about with relation to the cranial nerves. What about out in the somatic body? What kind of glands would you find in the somatic body? Well, how about sweat glands? How about sebaceous glands that deposit their secretion onto hair follicles? Sweat glands, sebaceous glands. How about some of the apocrine sweat glands in the axilla and in the anogenital area? Okay, so these types of glands are controlled by autonomic efferent fibers. We call these fibers GVE, general visceral efferent fibers. And when we talk about the GVE fibers being responsible for the control of smooth muscles and glands, what types of smooth muscles are we talking about? Well, we said that the effector organs for the autonomic nervous system include cardiac muscle, smooth muscle, and glands. When we're out in the somatic body, for example, in the arms and legs, the smooth muscles that we're concerned with generally are those muscles lining the arterioles and arteries. Recall the anatomy of an artery, and there's a large muscular layer known as the tunica media that can constrict and dilate to control blood flow and blood pressure. And that smooth muscle is under autonomic control through the general visceral efferent fibers. Now, the AMA guides don't mention, but we know that visceral structures, whether we're talking about the heart, the lungs, the gut, the stomach, the intestines, blood vessels, also convey sensory fibers responsible for feedback control, and these sensory fibers also travel in the spinal nerve roots. These are known as the GVA, general visceral afferent fibers, and of course, like the efferent fibers, these can be either sympathetic or parasympathetic. So the AMA Guides talks about three types of nerve fibers traveling in the spinal nerve roots, but we know that there actually are 4 different types of nerve fibers. And so we have all these fibers coming and going from the spinal cord, and so if you picture in your mind a cross-section of the spinal cord, and you've seen those cross-section diagrams before, and if you picture picture a cross-section of, say, the mid-thoracic spinal cord, we have fibers coming in on the sensory side, which are bringing sensory information from receptors mostly in the skin, but also from receptors in the muscles, receptors in the tendons, receptors in the joint structures, even receptors in the bone. In the bone, receptors are found in the bone marrow and also in the periosteum of bone, and so all these receptors are conveying information up into the spinal cord, and all of these sensory fibers have their nerve cell bodies in the dorsal root ganglion. The dorsal root ganglion in this example in the thoracic spine lies very close to the spinal cord. We're going to see later on in this program that in the lumbar spine, the dorsal root ganglion is many inches away from the spinal cord because we have the cauda equina, and we'll talk about the cauda equina here shortly. So anyway, information comes in from the periphery through these peripheral processes. Information travels up into the dorsal root ganglion, and then from the dorsal root ganglion, by way of central processes, the information then gets into the spinal cord, which, as we said earlier, is the integration and control center. From the spinal cord, information can go in any one of several different directions. In our example here, sensory information gets processed through the spinal cord, and then motor information or motor commands are sent out anterior horn cells, which are conveyed in the ventral root of the spinal cord, and then the dorsal root and the ventral root then coalesce or fuse and are wrapped in conjoined perineurium. And once we then see these roots combined or joined, we now have two-way traffic in the spinal nerve. We have sensory information coming up the spinal nerve, and we have motor information or commands going down the spinal nerve. And with regards to the motor commands, alpha motor neurons send commands to skeletal muscle tissue, and autonomic motor efferents, which have their cell bodies not in the anterior horn, but in the intermediolateral horn of the spinal cord. They send their information out, motor information commands out to cardiac muscle, smooth muscle, and glands. And then remember that, at least with regards to the sympathetic nervous system, very near to the spinal nerve root, traveling alongside the spinal nerve roots, we have the sympathetic ganglia that run up and down the spinal cord, extending from the cervical region all the way down into the sacral region. And it's those sympathetics are going to become important when we get into our discussion of peripheral nerve entrapment, specifically of the lower extremity. And the same pattern continues. But before we get into physical examination testing of dermatomes and myotomes, let's further discuss the anatomy now beyond the spinal cord, and let's review some of the important structures that are important, at least as far as the AMA guides are concerned, in determining permanent impairments of the spine and also of the upper and lower extremities. So once the spinal nerve roots leave the spinal cord, the spinal nerve roots coalesce then into the named peripheral nerves of the upper and lower extremities through either of the cervical plexus, the brachial plexus, the lumbar plexus, and or the sacral plexus. So let's spend some time now reviewing the plexuses. We have the cervical, brachial, lumbar, and sacral plexus, and we'll probably spend the most amount of time on the brachial plexus just because of its clinical applicability And also, in addition to the plexuses, I want to spend some time talking about the conus medullaris and the cauda equina, because there's some fascinating anatomy that takes place down at the terminal end of the spinal cord. And I know for a long time I really had very little understanding of the nuances of the anatomy down at the conus medullaris. So I've done quite a bit of research on that part of the spinal cord, and I want to share some of what I've discovered about the conus medullaris with you in this program. So let's review a little bit about this important anatomy now. So the cervical plexus is the first one that we'll talk about, and the cervical plexus is composed of nerve root contributions from C1 through C5, plus also a branch from cranial nerve number 12, the hypoglossal nerve. And I'll elaborate a little bit more on each of these plexuses as we go along here, but let's just outline the basic neurologic makeup of each of these plexuses. So that's the cervical plexus, and then the brachial plexus. The brachial plexus is formed from nerve root contributions of C5, C6, C7, C8, and T1, with also occasional contribution from C4 and also T2. And the AMA guides use the terminology inconstant contribution, is how the AMA guides refer to the contributions of C4 and T2. So for our purposes, we're going to consider the brachial plexus to consist of nerve root contributions from C5 to T1. Then we have the lumbar plexus, which is composed of nerve root contributions from L1 to L5. And then finally the sacral plexus consists of nerve root contributions of L3 through S3, and also S4 if you consider the pudendal nerve to be a part of the sacral plexus. And all of these plexuses and all of these nerve roots, all the way from the top of C1 to the bottom all the way down to S4, all of these nerve roots are mixed in that they carry all three of the types of fibers that are described in the AMA guides, and we even talked about a fourth type of fiber traveling in these spinal nerve roots, and that is there are both somatic afferent and efferent fibers. We refer to those as the GSA, or general somatic afferent fibers, and the GSE, general somatic efferent fibers. And then also traveling in these nerve roots are autonomic nerve fibers, again both sensory and motor fibers. Those we refer to as the GVA, general visceral afferent, and GVE, general visceral efferent fibers. And then once we have all of these plexuses, the cervical, brachial, lumbar, and sacral plexus, all of those nerve roots then coalesce into the named peripheral nerves that then travel out into the body and make up the bulk of the peripheral nervous system. Now, if you've ever seen listings of all the named peripheral nerves in the entire body, the list is extremely long, and we're not going to talk about each and every named peripheral nerves, but we'll talk about the ones that the AMA guides consider to be important, at least as relates to some of the common impairments that you'll see related to the head, related to the upper extremities, and then also related to the lower extremities. So out of the cervical plexus, probably the two most important named peripheral nerves that you may encounter clinical exam findings with will include the supraclavicular nerve and the phrenic nerve. In the brachial plexus, of course, you're all familiar with the axillary nerve, the musculocutaneous nerve, the radial nerve, the median nerve, and the ulnar nerve. And I remember in chiropractic school we had a mnemonic to remember the named peripheral nerves that come off the brachial plexus, and that was that my mother is usually always right. Musculocutaneous, median, ulnar, axillary, and radial. And in addition to those 5, I also list here for you the importance or an important peripheral nerve named the suprascapular nerve. And the reason I mention the suprascapular nerve is because I myself personally have recently run into 2 cases of suprascapular nerve entrapment at the scapula. There's 2 points of possible entrapment of the suprascapular nerve, and honestly, up until about 18 months ago, I had never heard of a peripheral entrapment of the suprascapular nerve. But since then, I've seen 2 bona fide cases of it, and it's a very interesting condition. Suprascapular nerve palsy is a very interesting condition. And so I mention that here as one of the named peripheral nerves from the brachial plexus. The suprascapular nerve is largely a C5 nerve. It also has, according to some authors and some textbooks, has contribution from C6. So I've seen 2 descriptions of the suprascapular nerve. Some texts describe it as a purely C5 nerve, while other texts describe it as being composed of contributions from C5 and C6. But anyway, it comes off of the superior trunk either immediately before C5 and C6 combine to form the superior trunk, or it comes off immediately after the superior trunk, after C6 has already come in and contributed fibers to comprise the superior trunk. So I've seen it described at least 2 different ways, and I mention it here for you to quicken your attention to possible cases that involve the suprascapular nerve. With the lumbar plexus, important peripheral nerves that we'll talk about include the ilioinguinal nerve, the iliohypogastric nerve, the genitofemoral nerve, the lateral femoral cutaneous nerve, and then obviously, of course, the femoral and obturator nerves. And then down in the sacral plexus, coming off the sacral plexus, important named peripheral nerves that you'll encounter in your examination of injured workers involve the inferior gluteal nerve, the superior gluteal nerve, the tibial nerve, the common peroneal nerve, and of course those 2 combine to give us the sciatic nerve. And then also there's a variety of different cutaneous nerves that provide sensation for the thigh and for the portion of the leg below the knee and even into the foot. Probably the most clinically encountered would include the posterior, would be the posterior cutaneous nerve of the thigh, causing pain in the back region of the thigh. So let's review now these plexuses, starting with the cervical plexus, which we'll just discuss briefly, and we'll spend more time on the brachial plexus, and I want to spend even extra time on the conus medullaris and share some of the fascinating anatomy of the conus medullaris with you. And then once we establish a good understanding of the anatomy of the plexuses and the named peripheral nerves, then in part 2 of this program we'll get into the neurologic examination of all these structures.